All right, y'all, we have made it to our second week and final week of talking about MDMA. So we'll cover just a couple of readings for this week. One from the textbook and then one on the only known, to me at least, or the only relational study that's been conducted with psychedelics, namely MDMA. All right, so this chapter explores the broader therapeutic and social implications of MDMA. Much of the current public conversation focuses on MDMA-assisted psychotherapy for PTSD, particularly the clinical trials conducted by MAPS, or the Multidisciplinary Association for Psychedelic Studies. However, the authors argue that MDMA's potential extends far beyond a single diagnosis. The chapter situates MDMA within a broader shift occurring in mental health care. Historically, psychiatry has emphasized suppressive approaches to symptoms, typically through medications that dampen emotional distress. MDMA-assisted psychotherapy represents a very different model. Rather than suppressing symptoms, MDMA appears to facilitate emotional access, introspection, and relational openness. Importantly, for the purposes of this course, the authors emphasize the relational and interpersonal effects of MDMA. They suggest that the medicine may have unique potential to support communication, empathy, and emotional processing within relationships. This becomes particularly relevant when we think about dyadic work, couples therapy, and relational healing. So the authors begin by contrasting two paradigms in mental health treatment. The dominant paradigm over the last 60 years has been suppressive psychopharmacology. Many psychiatric medications aim to reduce symptoms such as anxiety, depression, or intrusive thoughts. While these medications can be helpful, critics argue that they sometimes dampen emotional experience or limit deeper psychological processing. In contrast, psychedelic-assisted therapies, including MDMA-assisted psychotherapy, represents what the authors describe as an evocative model. Rather than suppressing emotional material, these therapies facilitate deeper exploration of the psyche. This approach assumes that many psychological symptoms arise from unresolved emotional experiences, trauma, or relational wounds. Under supportive conditions, accessing these emotional experiences may lead to insight, healing, and transformation. This shift is important conceptually because it reframes the role of medication. Instead of being taken daily to control symptoms, substances like MDMA are used episodically as catalysts within psychotherapy. So MDMA was first synthesized more than a century ago. We've covered that. But its psychological effects were not widely explored until the 70s or 80s, 1970s, 1980s. Several therapists and researchers began experimenting with this substance in psychotherapeutic contexts. Early practitioners observed that MDMA appeared to increase empathy, emotional openness, and interpersonal connection. These qualities made it particularly attractive for therapeutic exploration. Anne Schulgen played an important role in early therapeutic uses. She developed methods for facilitating MDMA group sessions and distributed guidance materials to therapists interested in the approach. Leo Zeff also conducted structured weekend retreats that involved group psychedelic experiences, including MDMA sessions. Another influential figure was Claudio Naranjo, who explored MDMA's potential for facilitating interpersonal insight and relational healing within groups of people who had ongoing relationships. However, in 1985, MDMA was classified as a Schedule I drug in the United States, which halted legal therapeutic exploration and pushed much use into underground settings. After MDMA was criminalized, recreational use expanded in underground cultural spaces, particularly in rave and electronic music communities. These communities often embrace the philosophy of PLUR, P-L-U-R, which stands for peace, love, unity, and respect. Participants frequently described MDMA as enhancing feelings of connection, empathy, and collective belonging. Interestingly, the authors note that many recreational users developed informal harm reduction strategies. These included sharing information about dosing, hydration, and safety practices within social networks. Organizations such as Dance Safe and the Zendo Project later emerged to provide harm reduction services at festivals and events. These groups offer drug testing, psychological support, and education aimed at reducing risks associated with substance use. This history complicates the dominant narrative that recreational users are simply reckless and hedonistic. Instead, many communities actively attempt to manage these risks and cultivate meaningful experiences. At the neurochemical level, MDMA primarily works by increasing the release of several neurotransmitters and hormones. Serotonin is one of the main chemicals affected. Increased serotonin levels are associated with improved mood and reduced anxiety. Dopamine is linked to reward and motivation, while norepinephrine contributes to alertness and arousal. MDMA also triggers the release of hormones such as oxytocin and vasopressin. Oxytocin in particular has been strongly associated with bonding, trust, and social connection. This combination of neurochemical changes appears to create a psychological state characterized by emotional openness, reduced fear, and increased interpersonal trust. These effects are particularly relevant in therapeutic contexts because they may help individuals discuss emotionally difficult material without becoming overwhelmed by fear or defensiveness. Neuroscientific research suggests that MDMA affects several brain systems involved in emotional regulation and fear processing. One important effect involves enhanced communication between the amygdala and hippocampus. The amygdala plays a key role in fear responses, while the hippocampus is involved in memory formation. Improved interaction between these structures may support the processing and integration of traumatic memories. MDMA also influences the hypothalamic pituitary adrenal axis, or the HPA axis, which regulates stress response in the body. Dysregulation of this system is often found in individuals with trauma-related disorders. Additionally, changes have been observed in the brain's salience network, which helps determine what stimuli are emotionally significant. Together, these effects may create conditions that allow individuals to revisit painful memories while feeling emotionally safe enough to process them. At the psychological level, MDMA produces a distinctive cluster of effects that differentiate it from many other psychoactive substances. Many individuals report feeling less defensive and more emotionally open. This reduction in defensiveness can allow difficult topics to be explored without the same level of psychological resistance that might occur in ordinary therapeutic sessions. MDMA also appears to increase empathy, both toward oneself and toward others. This can lead to greater compassion and reduced self-criticism. Another commonly reported effect is an increased ability to reflect on one's own behavior, emotions, and relational patterns with greater clarity. Taken together, these psychological changes create a therapeutic environment that may allow individuals to examine painful experiences while maintaining a sense of safety and emotional regulation. One of the most important features of MDMA-assisted psychotherapy is its potential to facilitate trauma processing. Under MDMA, individuals may gain greater access to memories or emotional material that has previously been avoided or suppressed. At the same time, the reduction in fear responses may allow individuals to revisit these experiences without becoming overwhelmed. Research suggests that MDMA may also enhance fear extinction, meaning the process through which the emotional charge of traumatic memories is gradually reduced. However, this process is not always comfortable. The authors emphasize that MDMA sessions can bring intense emotions to the surface. Painful memories, grief, or anger may arise. For this reason, therapeutic support and preparation are essential components of responsible MDMA-assisted therapy. One of the key conceptual differences between MDMA-assisted psychotherapy and traditional psychiatric medication is the pattern of use. Most psychiatric medications are taken daily in order to maintain symptom control. MDMA-assisted therapy, by contrast, involves only a small number of sessions. Typically, clinical protocols involve 2 or 3 MDMA sessions spaced several weeks apart. These sessions are embedded within a broader psychotherapeutic framework that includes preparation sessions before the experience and integration sessions afterward. The goal is not to suppress symptoms directly, but rather to catalyze psychological insight, emotional processing, and behavioral change. In this sense, MDMA functions less like a conventional medication and more like a facilitator of psychotherapy. An interesting aspect of MDMA-assisted psychotherapy training involves the role of personal experience with the substance. In MAPS clinical trials, therapists participating in the research were required to have a supervised personal experience with MDMA. The rationale behind this requirement is that therapists should understand the altered state their clients will be experiencing. Personal experience may also increase therapists' empathy and sensitivity during sessions. Additionally, these experiences can help therapists recognize their own emotional patterns, biases, and blind spots, which may influence therapeutic work. This mirrors the long-standing tradition of psychoanalytic and psychodynamic training, in which therapists are expected to undergo personal therapy as part of their professional development. One of the most intriguing areas of MDMA-assisted therapy involves its application in relationship work. Because MDMA tends to increase empathy and emotional openness, it may create conditions that support deeper communication between partners. Couples often struggle with defensiveness, misinterpretation, or emotional reactivity. MDMA appears to reduce some of these barriers, allowing individuals to express their feelings more openly and listen more compassionately. This does not mean that MDMA solves relationships problems automatically. Rather, it may create a psychological environment that allows partners to address long-standing conflicts more constructively. For therapists working with couples or families, these effects raise fascinating possibilities for facilitating relational repair. Qualitative studies of couples who have used MDMA, sometimes outside of clinical settings, provide additional insights into its relational effects. Participants often report feeling more emotionally connected to their partners during and after MDMA experiences. Many couples describe having conversations that feel more honest, vulnerable, and compassionate than typical everyday communication. Some researchers have proposed cognitive relational models suggesting that MDMA experiences may help couples gain insight into relationship patterns and integrate these insights into their ongoing interactions. Although much of this research is exploratory and not yet part of a regulated clinical practice, it highlights the potential relevance of MDMA for relational therapy. Although MDMA-assisted therapy is most widely studied for PTSD, the author suggests that it may have potential applications for other conditions. For example, addiction treatment may benefit from the increased insight and emotional honesty that MDMA can facilitate. Eating disorders such as bulimia often involve intense shame and self-criticism, which may be softened in MDMA-assisted therapeutic contexts. Similarly, anxiety and panic disorders might benefit from the reduced fear responses associated with MDMA. However, most of these potential applications are still speculative and require further research before they can be implemented clinically. The authors also discuss the controversial possibility of using MDMA-assisted therapy in child and adolescent populations. Their argument is that early trauma has enormous long-term impacts on mental health, and that more effective treatments could potentially reduce lifelong suffering. They speculate that MDMA-assisted therapy might help address trauma and attachment disruptions early in development. However, this idea raises significant ethical and clinical concerns. The use of psychoactive substances in minors requires careful consideration of safety, consent, and developmental factors. For now, such applications, go back. Okay. For now, here we are. Such applications remain speculative and would require extensive research and regulatory approval. All right. Many of the safety concerns associated with MDMA arise primarily in recreational contexts. At festivals or parties, individuals may take multiple doses, combine MDMA with other substances, or use drugs of uncertain purity. Environmental factors such as dehydration, lack of sleep, and prolonged dancing can also contribute to health risks. Because MDMA is illegal in many contexts, its production often occurs in unregulated environments, increasing the risk of adulterated substances, which just means impure, that they have other stuff in them. These factors complicate attempts to assess the inherent risk of MDMA itself. In clinical research settings, MDMA-assisted therapy follows strict protocols designed to minimize risk. Participants typically receive only only 2 or 3 MDMA sessions. These sessions are conducted in controlled environments with trained therapists present. Extensive screening procedures ensure that participants do not have medical conditions that could increase risk. Preparation sessions help participants understand what to expect, while integration sessions support the psychological processing of the experience afterward. These safeguards significantly reduce the risks associated with MDMA use compared to unsupervised recreational contexts. The authors also raise broader ethical and cultural questions surrounding MDMA-assisted therapy. One issue involves the tension between medicalization and community-based use. Some advocates believe that psychedelic substances should be available outside strictly medical contexts. Others argue that professional oversight is necessary to ensure safety and ethical practice. Questions of access and equity are also important. If MDMA therapy becomes legal but expensive, many people may not be able to access it. Finally, the authors discuss the philosophical shift toward recognizing the individual as an inner healer, with therapists serving more as guides or facilitators. This perspective challenges traditional hierarchical models of psychotherapy. In summary, MDMA-assisted psychotherapy represents a potentially transformative approach to mental health treatment. The compound appears to create psychological conditions that allow individuals to access emotions, memories, and relational dynamics in new ways. Its effects on empathy, trust, and emotional openness may be particularly relevant for relationship therapy and dyadic work. At the same time, ethical questions remain about safety, access, and appropriate context for use. As research continues, MDMA-assisted therapy may reshape how we think about the relationship between pharmacology, psychotherapy, and human healing. So then moving to our study using MDMA in couples therapy. So this article is especially valuable for this week's topic because it moves from broad claims about MDMA into a specific question. What actually happens in couples therapy when MDMA is used, and through what pathways might change occur? Wagner notes that MDMA's earliest therapeutic promise was actually in couples therapy, not only in trauma treatment. The article is not a large outcome trial. Instead, it's a theoretical mini review that synthesizes what we know from neurobiology, social psychology, and psychotherapy and early clinical work to explain why MDMA may be especially useful in relational treatment. A major contribution of this paper is its trans-theoretical orientation. That means Wagner is not arguing that MDMA only fits one model like CBT or EFT. Rather, she proposes that MDMA may enhance change processes that matter across approaches. She then organizes those ideas into the SET model: setting, structure, and safety, exploration and experience, and template and trust. So for MFT students, this article is helpful because it gives us a way to think systemically about MDMA, not only as a medicine that affects one person, but as a catalyst that may alter the emotional field between partners. So Wagner begins with a core relational premise: people do not exist in isolation. So healing in relationship may be especially powerful. Couple therapy allows change to occur in the same relational environment in which distress is maintained and in which healing must ultimately be lived out. The paper reviews several kinds of issues for which couples therapy may be relevant. These include straightforward relational concerns such as communication problems, intimacy struggles, trust injuries, infidelity, and life transitions. It also includes cases in which one or both partners are dealing with a mental health condition, such as PTSD, depression, or OCD. The implication is that couples therapy is not only for relational problems in the narrow sense, it is also a context for addressing individual suffering as it is embedded in a relational system. Wagner also emphasizes that although couples therapy can be effective, many couples either do not benefit sufficiently or fail to maintain gains over time. That creates space for asking whether MDMA might strengthen the very processes that make couples therapy work. Wagner reviews MDMA's neurochemical profile and then asks what those effects might mean in a romantic relationship context. MDMA increases the release and blocks the reuptake of serotonin, norepinephrine, and dopamine. It also elevates hormones and neurochemicals such as oxytocin and vasopressin, which are often associated with bonding and attachment, as well as cortisol and prolactin. At the brain level, MDMA is associated with decreased blood flow to the amygdala and hippocampus, increased activity in areas such as the prefrontal cortex and insula, and altered connectivity among structures involved in memory, emotion, and threat processing. Wagner's point is not merely pharmacological, it's relational. These effects may help create a state in which partners can remain emotionally engaged while being less overwhelmed by fear or reactivity. This is especially important in couples work because many relational conflicts are not simply about content, they are about the nervous system. Partners often cannot access vulnerability, empathy, or reflective functioning because they're flooded, defended, or bracing against threat. Wagner suggests MDMA may soften those barriers. One of the more interesting arguments in the article is that the neurobiology of MDMA overlaps with systems implicated in romantic love. Wagner notes that oxytocin and vasopressin are linked to attachment and bonding, dopamine and serotonin to pleasure and positive mood, and brain areas such as the amygdala, prefrontal cortex, and hippocampus to threat, reasoning, and memory. Her claim is not that MDMA simply manufactures love. Rather, in the context of a committed relationship and a therapeutic setting, MDMA may help partners access or remember neurobiological pathways associated with closeness, trust, and affection. That idea is clinically provocative. In many distressed couples, partners say some version of, "We used to feel so close, but now everything gets filtered through hurt, fear, or defensiveness." Wagner is suggesting that MDMA may temporarily reduce those defensive filters enough for a different relational state to become available. So Wagner situates the paper in both early history and emerging contemporary research. Before MDMA was criminalized, earlier clinicians such as Greer and Tolbert and the Shulgins described its usefulness in helping couples communicate and navigate relational issues. More recently, one pilot trial combined MDMA with cognitive behavioral conjoint therapy for PTSD. That was Wagner, her lab did that, with both partners participating in the full protocol, including MDMA sessions. Wagner highlights several promising findings from that work, including reductions in PTSD symptoms and improvements in relational satisfaction, post-traumatic growth, and social intimacy. This is important for you to know. The empirical base is still small, but there is enough preliminary work to justify serious theoretical reflection in future study. This article is part of building that conceptual bridge. So this is the heart of the article. Wagner organizes the literature into 8 cross-therapeutic outcomes that may explain why MDMA can catalyze couples therapy. Those outcomes are empathy, communication, perception of social connection and support, non-avoidance, openness, attachment and safety, bonding and social intimacy, and relationship satisfaction. What I like about this list is that it maps nicely onto processes many of you already know from different couple therapy models. EFT cares deeply about attachment and emotional accessibility. IBCT is concerned with acceptance, emotional softening, and behavior change. Gottman attends to conflict, repair, and friendship. Narrative and systemic models attend to relational meanings, emotional patterns, and interactional contexts. So one way to think about Wagner's proposal is that MDMA may not replace established couples models. It may instead amplify common change processes across them. Wagner first discusses emotions. She reviews evidence suggesting that MDMA can enhance empathy, improve perception of positive emotional expressions, reduce the social pain associated with rejection, and decrease defensiveness. It may also help people experience challenging emotions with more compassion and less fear. In couples therapy, that matters enormously. Distressed partners often cannot stay present with painful emotional content because they become defensive, withdraw, attack, or shift into self-protection. Wagner suggests that MDMA may allow difficult feelings to be experienced without immediately triggering the familiar interactional spiral. For example, a partner may be able to hear, when you pulled away from my disclosure, I felt abandoned, without instantly moving into a counterattack or shutdown. The substance may not remove pain, but it may soften the threat response enough that the emotion can be shared and received more fully. The second domain is cognition. Wagner notes that MDMA may help people engage with difficult memories because those memories feel less threatening. People may have more clarity of thought without becoming as emotionally flooded by what they are recalling. Some evidence also suggests that memories may become more tolerable and that fear extinction processes may be relevant. In relational work, cognition is not just about thoughts in the abstract. It includes interpretations, assumptions, expectations, and trust appraisals. A partner who usually thinks, if I tell the truth, I will be attacked, may be able to approach the conversation differently. A partner who habitually assumes the other is hostile may perceive more goodwill or at least more ambiguity. Wagner also cites evidence suggesting the possibility of new social learning. Clinically, that means MDMA may help disrupt rigid relational meanings and create openness to new interpretations of self, partner, and relationship. Wagner next turns to behavior. She notes that MDMA has been associated with greater willingness to disclose personal information, increased interpersonal focus in speech, greater cooperation, and reduced experiential avoidance. It has also been linked with increased openness to experience. In couples therapy, this has very practical implications. Many couples do not fail because they do not know what the issue is. They fail because they cannot enact the necessary behaviors when it matters. They cannot stay present, speak vulnerably, listen non-defensively, or remain engaged when the conversation becomes emotionally charged. MDMA may create a richer behavioral environment for therapeutic work by increasing willingness to communicate and tolerate vulnerability. Importantly, that does not mean all disclosures are automatically wise or all relational risks are automatically safe. It means the therapist's role in structuring and containing the experience becomes even more important. The fourth domain is somatic experience. Wagner notes that MDMA may bring up strong physiological sensations linked to past experiences, while also sometimes producing calming or soothing bodily states. These embodied experiences can be clinically meaningful, especially when trauma or attachment injuries are encoded not just as narratives, but as bodily reactions. For couples therapy, this matters because relational distress is deeply embodied. Partners often register danger in each other's tone, posture, timing, and facial expressions before they can articulate it cognitively. If MDMA helps reduce fear responses and increase closeness, then the body may become more available as a site of healing rather than only alarm. A partner may notice, for example, that hearing their spouse's repair attempt no longer produces the same tightening in the chest or urge to flee. Or they may finally feel the name the bodily vulnerability that has sat underneath anger for years. So identifying that primary emotion that's sitting under that secondary emotion. Empathy is one of Wagner's central pathways. MDMA is associated with increased emotional empathy and with perceiving others as more caring and trustworthy. In couples therapy, this may create a powerful opening because empathy is often precisely what distressed partners feel they have lost. Wagner's table is useful here because she pairs each pathway with possible interventions. For empathy, she recommends centering both people's experiences and facilitating the sharing of feelings. This is a very systemic point. The therapist should not create a one patient or one helper dynamic. Both partners must be understood as full participants in the relational field. This is especially important ethically in dyadic work because unequal centering can quickly become an enactment of power or an invalidation. Wagner identifies three closely linked processes here. First, communication may improve because MDMA is associated with more interpersonal language and less reactivity to anger cues. Second, perceived social connection and support may increase. Third, non-avoidance may be strengthened, allowing difficult experiences and conversations to be approached rather than evaded. This is such an important trio for couples therapy. Many couples become stuck, not because they are incapable of insight, but because they cannot stay with the conversation long enough to metabolize it. They avoid, escalate, pursue, defend, or detach. Wagner argues that MDMA may support the kind of emotional and behavioral approach necessary for real relational work. Her intervention suggestions include practicing sharing and listening skills, highlighting strengths during integration, and explicitly framing non-avoidance as important for growth. That aligns well with what many of you already do in relational therapy: naming avoidance, scaffolding safer engagement, and reinforcing moments of connection. The remaining pathways are highly relevant to attachment-oriented work. Wagner argues that MDMA may increase openness and reduce neuroticism, support feelings of interpersonal trust and safety, strengthen bonding and social intimacy, and ultimately improve relationship satisfaction. Notice the progression here. Openness makes it easier to risk being known. Safety makes it easier to stay engaged. Bonding grows through shared vulnerability and co-regulation. Relationship satisfaction may improve not only because conflict disappears, but also because partners experience themselves as more connected and better able to cope and navigate distress together. Wagner's table also suggests practical interventions, establishing shared intentions, teaching skills for difficult conversation and re-engagement after breaks, engaging the couple in the whole process together, and encouraging shared experiences throughout treatment. For MFT students, this is a good reminder that drug effect alone is not the point. The point is how the medicine-supported state is translated into a relational process. Wagner's major clinical contribution is the SET model, again, which stands for Setting, Structure, and Safety, Exploration and Experience, and Template and Trust. The model is meant to capture the essential components of MDMA-assisted couple therapy, regardless of theoretical orientation or presenting issue. This is especially useful pedagogically because it helps you as students, and it gives you a way to organize the treatment process without getting stuck in one theoretical camp. You can still practice EFT, CBCT, IBCT, or any other modality, but Wagner is saying there are common features of effective MDMA-assisted dyadic work that deserve explicit attention. So I would frame the SET model as both a clinical scaffold and an ethical scaffold. It helps answer questions like, how do we prepare the couple? How do we protect safety? How do we facilitate rather than over-direct? And how do we help the gains generalize after the medication session ends? The first part of the SET model is probably, the most ethically important. Wagner recommends beginning with a thorough assessment of commitment, distress, co-occurring mental health challenges, couple history, and goals. This is followed by feedback and collaborative case conceptualization. Preparation includes empathic communication skills, intention setting, and practical logistics. Wagner is clear that safety must include explicit discussion of how to stop disagreements before they escalate, how to return to conversations when the couple is more settled, and the absence of interpersonal violence. This is a crucial point for y'all. MDMA-assisted dyadic work is not appropriate for every couple. Safety is not a vague vibe, it's a concrete clinical requirement. She also emphasizes that both people's experiences are central and that there is no single patient in the room. That stance can mitigate power dynamics and create more opportunity for both partners to engage fully. The second component of the model is exploration and experience. Wagner emphasizes fostering curiosity, openness, and non-avoidance before, during, and after MDMA sessions. The goal is not to control every moment with an agenda, but to create conditions in which meaningful experience can emerge and be engaged. She also recommends helping couples revisit insights, shifts, and gains over time. Because couples often drift back into old patterns, exploring difficult conversations is not seen as a failure of the session, it is often part of the therapeutic opportunity. In fact, Wagner suggests that these shared difficult experiences may help create empathy, bonding, and a stronger perception of support. So for y'all, this is a useful balance. The therapist is neither passive nor rigidly directive. The work involves responsive facilitation, making room for what emerges while also keeping the couple connected to the broader therapeutic arc. The final component is template and trust. Wagner argues that the process of MDMA-assisted couples work can create a template for how partners communicate, debrief, and navigate intense emotions in the future. In other words, the MDMA session is not the endpoint, it is a catalyst for a new relational pattern. This is especially important in couples work because even a powerful emotional breakthrough means little if the dyad cannot translate it into everyday life. Trust here includes trust in the partner, trust in oneself, and trust in the relationship's capacity to tolerate and metabolize distress. Wagner suggests reinforcing strengths, supporting non-avoidance, and highlighting the couple's ability to navigate stressors together. So a teaching question I have for you is, what exactly becomes the template? Is it the emotional tone of the session, the communication practices, the memory of safety, the felt experience of being understood, or all of the above? Okay, so the diagram on page 5 lays out a practical sequence of treatment. It begins with assessment, followed by feedback and case conceptualization, then preparation, 1 to 3 MDMA sessions, and finally integration. The figure also specifies elements within each phase, such as communication skill building during preparation and applying insight to relationship life during integration. This figure is especially useful for y'all because it helps you see that MDMA-assisted couples therapy is not just give the couple MDMA and see what happens. It's a structured therapeutic process. The medicine session sits within a larger arc of assessment, preparation, facilitation, and integration. That structure also reinforces ethical responsibility. The more powerful the intervention, the more important preparation and integration become. So although Wagner's article is optimistic, your module title for this week emphasizes ethical complexity. So this is where there are implications for the work. First, dyadic work always involves power. When a medicine heightens openness, trust, and disclosure, therapists must carefully monitor whose voice is being centered, whose needs are being privileged, and whether one partner is subtly dominating the frame. Wagner directly addresses this by insisting that both people's experiences be central and that there be no single identified patient in the room. Second, safety is non-negotiable. Wagner explicitly includes conversations about escalation, re-engagement, and the absence of interpersonal violence. That means clinicians must screen rigorously rather than assuming relational work is automatically healing. Third, MDMA may lower avoidance and increase disclosure. That can be therapeutically useful, but it also raises questions. What happens if a major secret emerges? What if one partner feels pressured into emotional exposure? What if the couple leaves the session in different places emotionally? These are not arguments against the work, but they are reminders that the dyadic frame amplifies both possibility and responsibility. So in closing, Wagner gives us one of the clearest conceptual models for understanding MDMA in couples therapy. Her argument is that MDMA may catalyze change through relational pathways such as empathy, communication, non-avoidance, attachment, intimacy, and trust. The SET model is especially helpful because it offers a flexible scaffold for practice while still leaving room for different therapeutic orientations. It also foregrounds structure and safety, which are essential in ethically complex dyadic work. At the same time, Wagner is clear that the research base is still limited and that much of the model remains theoretical and preliminary. She specifically calls for more investigation of MDMA in dyadic contexts, since much existing research has focused on individuals rather than couples. The article is best understood as a bridge text. It connects neurobiology, attachment, interpersonal processes, and clinical structure in a way that can help researchers and clinicians think rigorously about both the promise and the complexity of MDMA-assisted relational therapy.